It's good. So I'm on our Grady primary rotation. So every ophthalmology program is a little bit different. We have two resident run clinics. One of them is at Grady, which is our county hospital here in Atlanta. So we always have attendings that staff our clinic, but it's really a resident run clinic. Residents are seeing all the patients first and staff them attending. It's definitely one of the busier rotations. We, see a lot of patients. We have different subspecialty days. So today actually was just comprehensive. So we just had a comprehensive attending there. But like tomorrow we have surgical retina and then some comprehensive patients too. So we still get a mix of the subspecialty care, but it's all resident run. As one of the first year residents, we also cover the day consults at Grady. So sometimes you feel like you're a little bit torn in a couple directions, trying to cover the day consults and see clinic patients. But it's good. We actually also had one of our neuro-ophthalmology attendings, Dr. Newman, came today to staff some patients as well. So did have a little bit of subspecialty. But yeah, every Grady's good because every day is a little bit different. You really see some really pretty advanced pathology there, which makes for good training. A lot of good surgical experience comes at Grady. And there's something to be said for, all of these are your patients. You're the one kind of, making the final call and really saying what you want to do with the patient versus an attending clinic, which, you see also, really advanced and interesting cases like at Emory, advanced pathology. But when it comes down to it, the attending is going to be in there, see the patient, kind of decide what they want to do for themselves. Whereas at Grady and at the VA, you really take more ownership since it is a resident run clinic.
Gotcha. Interesting. So I guess maybe it sounds like you covered kind of what you guys do on the outpatient side of things, but maybe take us through like a typical day on the inpatient service for you guys. Like, is it mainly consults? Do you have like your primary patients? And then obviously how does surgery fit into that as well?
Yeah. So we don't really have like a primary service. Every once in a while, we'll have a trauma that gets admitted to our service overnight if they come in with an open globe injury. So anything that the globe is violated and we have to take them to the OR the next day. But sometimes they're likely to have other traumatic injuries. They'll get admitted to the trauma service or the medicine service. We don't have any residents that are specifically just covering consults or just covering the inpatient census. It's usually one of the first years is kind of, in charge of the patient while they're on the floor. Ophthalmology is actually kind of starting to switch over to all the transitional years have to be at the same location where you're doing your advanced ophthalmology program. So we have a transitional year, at least one with us, basically all the time at Grady. So they help us out a ton with seeing patients on the floor for consults, seeing patients in the emergency department for consults. And then it's the first years that take call overnight. So the interns, we don't take call or anything overnight. I'd say on an average day, as far as during the day for inpatient consults, we probably get 4 to 5 that are on the floor throughout the hospital for different things, whether it's like a fungemia in an ICU patient and they want to rule out if there's any ocular involvement, to someone, with some red eye and the primary team is not exactly sure why. And then we, probably get 4 to 5, maybe a little bit more in the emergency department, either coming with acute eye pain, coming in with trauma, any like eyelid lacerations, we usually have to go down and repair. And then sometimes we'll get some calls too from like the urgent care center across from Grady and try to triage those patients and decide if they need to go to the emergency department, if they can come up to eye clinic, or really figure out the best way to get them seen and get them taken care of. So it's not like a lot of other surgical services where, they have patients that they took to the OR and then they have them on the floor for a few days or taking care of them post-operatively. Basically all of our surgeries, patients can be discharged the day of. It's all outpatient surgeries. Sometimes the patients stay inpatient if they have other medical comorbidities, but we're not like getting numbers in the morning and rounding and all that sort of stuff. If we have patients that we're following that are inpatient, like have a corneal ulcer or something else we're following, 1 or 2 people will just kind of go see them when they have time in between patients in clinic or before clinic starts.
Gotcha. And if I remember, actually, you telling me this last year when we were rotating the ED together, that an ophthalmology consult can actually take considerably more time than one may realize. And so I was wondering if you could maybe touch on that. And then also you guys carry around some interesting and cool looking equipment. So maybe if you could tell us a little bit about that, some of your gadgets that you guys use.
Yeah, definitely. Ophthalmology has a lot of new technologies and a lot of gadgets we use all the time. Most of them are more in like some of the cooler ones, are in the clinic and the operating room. But even still on the floor consults, one of the reasons it takes more time is ophthalmology is a very exam focused specialty, and just kind of getting the story. And even if the emergency department got imaging, there's not really enough there for us to make a decision and decide what we need to do with the patient. So basically, all patients, if there's a real question that the emergency department has, we have to go see them in person, compared to maybe some other surgical subspecialties who can, so we recommend this imaging, these lab tests, and then we'll round on them and actually see them in the morning. So everyone that we see, we have to do a pupil exam, get a vision, get the eye pressure, which usually we use what we call as an eye care or a tono pen, and that's a way to get the eye pressure in the emergency department. So that's one of the big boxes we're usually carrying around. And then we check extraocular movements, and then check like confrontational visual fields. And those are kind of all what we refer to as the eye vitals. And that's one of the things, if any of your listeners aren't going into ophthalmology, but are going into emergency medicine or even internal medicine, if you can get all of those eye vitals, it's really helpful for us to help triage things. A lot of times, most emergency departments have something to check eye pressure. I know a lot of times on the floor, that's not quite as easy to get, but those can really help us decide, because every once in a while, we'll get two consults at the same time, or sometimes overnight we're covering multiple hospitals. So it really helps us triage things that way. And then the majority of our time spending on consults is we have to dilate all our patients, and the dilating eye drops don't work right away. So we have to put the dilating eye drops in, wait, 15, 20, 25 minutes, and then use the indirect ophthalmoscope, which isn't one that's hanging on the wall. It's the one that we wear on top of our heads. Looks like a special ops person with the little glasses in front and stuff. And use different lenses to kind of look in the back of the eye, look at the optic nerve, look at the retina, and make sure there's nothing going on that's visioning threatening that has to be taken care of that night.
Gotcha. What are like the common things where like you guys would have to say, like, we have to go to the OR, like either that night or, the next day or something like that? What are those types of consults or pathology you guys would see?
Yeah, the biggest one for us, at least at Grady, especially, and that's where I am now, so that's kind of where my mind goes right away, is trauma and open globes. So we get consulted on basically all of the orbital fractures, but those very, very rarely have to go to the OR right away. If one of the extraocular muscles is entrapped, you would recommend to go to the OR more urgently, but most adults have pretty brittle bones in the extraocular muscles that are actually getting trapped. So it's a little more common in kids. But one that we see a lot and go to the OR a lot with are open globes. So any penetrating trauma to the eye, gunshot wounds to the eye, those sorts of things really should be repaired urgently, within, I don't know, anyway, 18, 24 hours is kind of pushing it. We usually try to post it within 6 hours, try to get to the OR sooner rather than later. So that's the biggest one. The other one you always hear about are retinal detachments. And really before starting ophthalmology residency, I didn't realize all the kind of nuances with retinal detachments, and there's different types of retinal detachments. And so retinal detachments that are associated with diabetes, like a tractional retinal detachment, that's something that's been going on chronically and been going on for a long time. I know my first few nights on call, I'll get a page from the ED that, some retina surgeon somewhere else in Atlanta sent their patient to Grady with a retinal detachment, and kind of freaked me out. Like, what am I going to be able to contribute that this retinal surgeon, outside that's been in fellowship for 2 years, finished a residency, what am I going to contribute? But a lot of times what it ends up being is they're a diabetic and they have this tractional retinal detachment that's not an emergency and can be taken care of on an outpatient basis. The retinal detachments we worry about are the rheumatogenic retinal detachments, people that have longer eyes, are nearsighted, and that's like the classic. I saw a bunch of flashing lights, hundreds of floaters coming over my vision, then a veil coming over my vision. And why we like to intervene on those more urgently is because if it goes to the macula, the center part of the vision, the outcomes aren't as good if you repair earlier, the outcomes are better than if you wait till it involves the macula. Even sometimes some of those, if it's not truly detached all the way or only part of it's detached, we can do laser procedures or other things to kind of keep it from going into the macula. We might not necessarily have to go to the OR in the middle of the night. And I guess the other one is some oculoplastic conditions, like any lid lacerations. A lot of times it's going to be repaired at bedside, but if they involve the tear drainage system of the eye, the canalicular system, sometimes those need to go to the operating room to make sure the patients don't have problems with tearing after the injury and after the repair.